Doctor's Data offers the GI360 stool test as an extremely comprehensive assessment of the gastrointestinal microbiome. GI360 is actually a test within a test because we have an analysis of microbiome abundance and diversity where we are looking at 45 different analytes that have been shown to contribute to a healthy gut or a dysbiotic gut in specific parameters. All that information is computed to create an abundance and diversity matrices, dysbiosis index, and diversity score. Additionally, that information is organized into functional guilds. So clinically, you can have the information where your patient lies with regards to butyrate producers, intestinal health markers, and that information is very valuable because this is the foundation for your patient's microbiome, which also greatly influences systemic physiology and health. So Doctor's Data GI360 includes that information in addition to culture for dysbiotic bacteria, which we also provide the sensitivity information. So you have individualized medicine here. You are able to look at what is going on within your patient's microbiome, as well as the presence of dysbiotic organisms, and use actually individualized medicine that has been validated by science to treat your patient. GI360 also includes 3-day parasitology testing and a stool chemistries information. The stool chemistries is a wealth of information in one test. So we're looking at digestion, absorption, immunology markers, short-chain fatty acids, and also including beta-glucuronidase and macroscopic appearance. So GI360 really does cover the most clinically relevant information that you'd want to address with regards to your patient's microbiome, and also has some implications for systemic physiology. As GI360 is a test that is linked to systemic physiology, there's abundance of information there that we can really think about other aspects of human health. One of those markers is beta-glucuronidase. Beta-glucuronidase is an enzyme that is responsible for cleaving glucuronic acid and toxins. So your body will bind toxins to excrete them via the feces. In some individuals, we see elevated levels of beta-glucuronidase, and this might be associated actually with excess estrogen as well, because the body will bind estrogen to excrete it. And if there's higher beta-glucuronidase, then that enzyme has cleaved that binding, and estrogen is actually available in the colon to be recirculated back into systemic circulation. So we do really see this link here between stool testing and hormone testing actually. So beta-glucuronidase is an important marker that we're paying more attention to. So the GI360 allows for the analysis of the gastrointestinal microbiome. And here we're looking at the DNA of 45 different analytes that have been shown to contribute to a healthy gut or a dysbiotic gut. So the GI360 adds more information to understand really the encompassing complexity of the human microbiome, and it puts it in clinically applicable information, providing the dysbiosis index and the diversity score, and organizing this information into functional guilds. So you have very advanced information at your fingertips. Susceptibility testing is an excellent tool for individualized medicine. At Doctor's Data, when there is a cultured bacteria or yeast, we actually take that specific organism and put it in vitro with these agents, and we let you know which agents killed that yeast or bacteria. That way you have that information for the specific organism that is unique to your patient. We're not using wall charts, that is data that says X organism is killed by this agent. We're not doing that actually. We're taking the yeast and the bacteria that's from your patient's sample and putting the agents directly in the lab and reporting that information to you. So this is a unique and very helpful aspect of our testing. The CSAP and GI360 are both excellent tests. They both identify stool chemistries, parasitology, dysbiotic bacteria and yeast will both be cultured with sensitivities. The main difference is that the CSAP will identify beneficial bacteria via culture, and that provides excellent information about the bacteria that are in the colon. And then the GI360 is a newer test. With the advent of DNA technology, we're actually able to look at the microbiome and the bacteria within there as they equate to microbiome abundance and diversity.
So the 360 was a marvelous assay to bring forward. The microbiome portion of that was very exciting. We spent a lot of time collaborating with our colleagues in Norway in a whole brand new area for doctors' data. But I think the important thing is not only did we bring a really interesting test live, but we've continued to work with it. New data, new steps, new reports, new pieces of information that are valuable for our clinicians to understand beyond that initial microbiome work. So some of the more recent steps have been the addition of the diversity score and the abundance scores to look at beyond just the primer sets and the organisms, sort of what's the next level. And I think we've got some fascinating things that we can do beyond that, because doctors' data has a massive data set. The number of patients that we look at here is actually almost unbelievable. And so our ability to manipulate that data and look for trends and analysis is actually phenomenal. And so I expect in the next couple of years we'll continue to look at the information that we have and analyze it in a way that helps our clinicians with our patients. Because I have to say, simply another PCR assay isn't really valuable unless it connects in a new and unique way to our patients. So for example, we don't know exactly how that's going to fit in some populations like pediatrics. What's the microbiome and how does it change? What is dysbiotic for a 13 or a 14-year-old? We don't know, but we have the information and the capacity to begin to look at those unique patient populations. We also are going to continue to collaborate with our colleagues in Norway, with GA, to understand what kind of additional manipulations of the primer sets and the organisms we can do to, again, improve the test and what information we can give our clinicians in their therapy for their patients. We also are looking now at things like inflammatory markers. With large patient data sets, we can connect things within the assays that we do here at Doctors Data to look at unique connections. What do we know about the microbiome and how that connects to various inflammatory markers of perhaps, again, some unique patient populations to help us predict clinical conditions and possibly monitor therapy. So collaborating with the group in Norway, with GA, was a fascinating process. They had developed the assay there. So the way they did the primer selection sets were really not just what primer sets and organisms can we identify. There's thousands and thousands of primer sets for all kinds of unique organisms. So simply developing an assay because you can put primer sets together, doesn't make it anything useful. And I think that's really important to understand about this assay, is that they took lots and lots of primer sets, looked at lots and lots of different organisms, and then said, which of those are relevant? How do we connect this to actual patients? Because patient care is the goal here. It's not just putting together a fun assay that you can market as something. And so in this case, the primer set was narrowed down because of the ability to separate dysbiotic and normobiotic patients. There's a lot of publications that have been made to look at important patient populations and the ability to be separated by this particular primer set. So again, it's not just I can do all of these, but how does it connect and how is it useful for our clinicians when they're looking at patients? So I think the present state of the art is critical to understand here. We have molecular methods that we use at DDI. We do the microbiome assay, which is an important piece of the 360. We do the PCR, state-of-the-art, FDA-cleared assays for important pathogens. But we still do conventional culturomics. And that's for a couple of reasons. One, the rest of it isn't sophisticated enough to do everything that we think is important. And so we still do conventional cultures because of its ability to answer questions that are a little bit different than the microbiome or even the pathogen. So organisms that are out of balance, we can give it genus and species and then potentially look at botanical or prescriptive agents that might be needed by a clinician to alter some of that flora. And the only way you can do that is to actually have the bacteria isolated in the laboratory to do that in vitro testing. And we're very, very happy at Doctors Data to be able to answer some very specific questions about prescriptive antibacterial agents and antifungal agents, but also the entire world there in functional medicine, where we might want to try to alter normal flora with botanicals or natural agents rather than prescriptive agents. And again, the only way to do that is to have the organism isolated in the laboratory, expose it to the agent, see if it works better than this one or that one. And that all relies on our long-standing ability to do conventional cultures of aerobic organisms and anaerobic organisms. In addition, there's some very unique opportunities that culture presents itself. So let's say that there's a perhaps unusual circumstance, but a clinician is like, I'm interested in specifically focusing in Clostridium. The way to do specifically focusing on Clostridium is to culture for them and to separate one group of Clostridia from another group. For example, then, we isolate Clostridium. Well, how do we identify all the different possibilities that we can culture? And that's one of our major uses of mass spec time of flight, or MALDI-TOF, is the ability to take thousands and thousands of different protein fingerprints and allow us to identify those organisms that we've cultured at a very, very sensitive and specific way using mass spec time of flight. It requires a tremendous amount of technologist experience and the technology of mass spec time of flight, which again isn't simple to use, but gives us the sensitivity and specificity to do these very specific, specialized circumstances that support the overall 360, the microbiome, the pathogens, the inflammatory markers, and the other pieces, but this unique moment where we can really drill down into groups and subgroups of very specialized organisms.
Hello, everyone. Let's explore a GI360 case together. Here we have the case of a 20-year-old male who is reporting to his physician due to GI distress after exploring with a carnivore diet. The patient had learned about a carnivore diet on social media and has been exploring with this diet for the past 3 up to 4 months. Let's take a look at the GI360 results. The first piece of information we have here is the web. The web is a visual representation of abundance and diversity by phyla. We can see here the patient's result is that white web that is superimposed on the normal biotic reference range, which is that green hexagon there. The first piece of information we can look at is abundance. With regards to abundance, if that web is very small and pulled in, this shows decreased abundance. The second piece of information we can look at is diversity. If this is making a hexagon, this shows appropriate microbiome diversity. If this is making a square or a triangle or a rectangle, which you will see those results, that shows that there is diversity issues. And so in this report here, we can see that the patient's result is somewhat pulled in and it's skewed towards the proteobacteria. So that's showing moderate abundance and also moderate diversity. So there are some improvements to be made. Let's dive a little deeper into the bacteria phyla. Again, this web is represented by phyla. This is broad-based information. The first piece of information we have is that the actinobacteria are pulled in, that's lower. Actinobacteria really like vegetables, and that's a clinical pearl here, is that the lower abundance of the actinobacteria phyla indicates a need for vegetables. And that makes sense based on the patient's diet. The next piece of information we have is the vermicroba, and those are pulled in. Tourniquets are within range. We're going clockwise here. And the proteobacteria are actually higher, and that does make sense because proteobacteria like excess fats, excess proteins, and that could be part of the carnivore diet. Moving along, the next phyla we see are Firmicutes. Those are pulled in as well, a little bit lower. Firmicutes has a wealth of bacteria within there, and we'll look at some of those specific species, including the fecal bacterium Protnitzii. That's a very healthy butyrate-producing keystone bacteria. The next piece of information we have is Bacteroidetes, and those are pulled in as well. So overall, we're showing lower abundance and a disruption in diversity. Let's take a look at the next piece of information we have, which is the dysbiosis index and the diversity scores. These analytes are a summary of your patient's microbiome, looking at specific bacteria in the values that contribute to dysbiosis and diversity. The dysbiosis index was studied with regards to IBS, IBD, obesity, diabetes. So this is an excellent piece of information here, and you can show your patient the numerical value. With regards to dysbiosis, scores go from 1 to 5. 1 and 2 are healthy, normal biotic guts, and then 3, 4, and 5 are dysbiotic guts. So for this patient, we can see there is a dysbiosis here as indicated by the dysbiosis index of 5. The next piece of information we have is the diversity score. Diversity is a very interesting matrix in that it is really foundational, and it is associated to not only microbiome and colonic health, but also systemic physiology, everything ranging from hypertension, cardiovascular implications, to extroverted behavior, anorexia nervosa. Microbiome diversity is a very important foundational piece of the colon with implications with regards to human health. There's a lot of research in this area right now, and I anticipate that we will see more and more in the future. Microbiome diversity, we want a healthy, diverse microbiome. So scores of 4 and 5 are very healthy, 3 is moderate, and 1 and 2 are lack of diversity. With regards to this is akin to an ecosystem such as a rainforest or a prairie. We know that a rich, diverse ecosystem has a variety of flora and fauna, and it is the same within the human colon in that a diverse ecosystem is a healthy human colon. The piece of information here for this patient, we can see that their diversity score is 3. So this is moderate diversity. So we have some improvements to be made with regards to diversity and with regards to dysbiosis. Let's take a look at the key findings. The next piece of information we have here are key findings. For key findings, there are 2 columns. Sometimes people like to equate these 2 columns by the first row, second row, etc. The way that this report is actually designed is that first column of key findings, these are functional guilds, and this is the same information that we've had with regards to the web, the diversity and dysbiosis indice, and now we're taking that information and we're looking very detailed into the specific bacteria that are associated with a function. So the first piece of information we have are the butyrate producers. These are the bacteria in the colon that result in butyrate production, whether they are expected or imbalanced. So if they're imbalanced, they're too low. That's what this patient has here. And you want to support the butyrate producers with soluble fiber. The fiber feeding approach is the best evidence to support the
butyrate producers. And then we have other functional guilds for specific bacteria in that first column. The second column, though, is additional findings on the report. So stool chemistry is cultured bacteria, cultured yeast, like we have here, any parasites, viruses, things of that nature that will be printed in the second column there, and that is going to be the significant findings of the report. So this is an excellent summary. Now let's go back to understanding this patient's results. For the key findings, we see that these butyrate producers are lower. So like I said, we're going to employ that fiber feeding approach and support the butyrate producers 8 to 15 grams of soluble fiber per day. That's going to be the Jerusalem artichoke, red kidney beans, lima beans, chickpeas, hummus, and based on the patient's history, we can consider the fact that the carnivore diet is actually absent of these soluble fibers that are so important for the microbiome. So this is a good piece of information here. The next functional guild we have is going to be the gut barrier protective bacteria. We know that the human colon is very important because it's where that external environment meets the internal environment, human physiology, and the gut barrier is really integral to that entire process. There are specific bacteria that really contribute to keeping a healthy mucosal barrier integrity. These are the bacteria represented here. So for this patient, we know that those bacteria that are involved in that healthy mucosal barrier integrity are lower. In this case, the patient is going to be at risk for decreasing mucosal barrier integrity and then intestinal permeability. That potentially allows for translocation of inflammatory bacteria and products. The next piece of information we have is the gut intestinal health markers. And then that is within range for this patient. The pro-inflammatory bacteria are in range for this patient as well. And then the last piece of information we have is that balance between the gut barrier protective bacteria versus the opportunistic. So we know the gut barrier protective bacteria are outside the reference interval, and we know that the opportunistic bacteria are elevating. So we want to bring this patient back into balance. With regards to the gut barrier protective bacteria, those are too low. We want to support them. Soluble fiber is an excellent foundational piece here. We can use polyphenols as well. And then you could also employ your own nutraceutical protocol, whether that be aloe vera, L-glutamine, marshmallow, things of that nature. So you have a variety of options there. The gut barrier protective versus opportunistic bacteria will be remediated by supporting those gut barrier bacteria. And then we're going to also think about here the web. We know the proteobacteria are too high, and those like excess fats, excess proteins. So we're going to decrease the dietary consumption of excess protein and fat and increase the dietary consumption of soluble fiber and polyphenols. The next piece of information we have is going to be the second column. Like I mentioned previously, that second column is independent of that first column. For this patient's result here, we see there is lower beta-glucuronidase. Lower beta-glucuronidase has not been associated with any significant physiologic outcome at this moment. The research has associated it, though, with low diversity. So the patient has a moderate diversity score. Once that's remediated, potentially this will be remediated as well. The next piece of information we have is the information about the cultured bacteria for this patient sampled. There is a cultured Enterobacter cochleae complex and a cultured yeast, Rhodotrula yeast species. And you will see at the end of this report, what Dr. Zeta has done is taken those specific organisms and put them in vitro with natural and pharmaceutical agents. And then we've reported to you exactly which natural or pharmaceutical agents were effective against that particular yeast or bacteria that was cultured from your patient's sample. Again, this is not wall charts. This is direct in vitro information that could be utilized as treatment guidelines. So this is the first page of the report. Now let's take a look at the detailed information. The next 3 pages are regarding microbiome, abundance, and diversity, and the detailed information about those key findings. Here we see the actinobacteria are lower, and remember, they like vegetables, so we really want to support them with vegetables. The bifidobacteria are lower as well, and this is another need for soluble fiber. The next phyla we see is the Bacteroidetes, and we see that this is generally within range, although we have a few that are lower. The Firmicutes phyla, we can see that the Firmicutes are lower as well, and the bacilli class. So again, another need for soluble fiber to support these bacteria. The next page, we will see variety of bacteria within the Firmicutes phyla. I will draw your attention to the fecal bacterium Proteinaceae. That is a keystone bacteria that is a major butyrate producer. So this bacteria really likes soluble fiber, and then when it's lower, the patient's going to be at risk for lower butyrate and inflammation in the colon. So we want to support that bacterium. Of note, the very popular lactobacillus is lower as well. They like polyphenols, and if you wanted to use a probiotic, you can. Those are temporary, but they can hopefully take up residence in the colon, and then you can feed them to continue to support the microbiome. The next page, we have the last three phyla. We have the Firmicutes and the Proteobacteria phyla. We'll take note here that the Proteobacteria and the Enterobacteriae are elevated. Again, this is due to the carnivore diet. The carnivore diet tends to have excess dietary fats and proteins. So there's a dysbiosis here, or dietary-induced dysbiosis. The last piece of information that we'll pay attention to here is this Akkermansia muciniphila. This is the mucus-loving bacterium here. And when it is lower like this, you want to support it with soluble fiber and polyphenols, really. With regards to Akkermansia, pomegranate is always talked about as a dietary approach to increase this. So there's some things we can do to help this patient with regards to that dysbiosis and that diversity score at the front page. Let's take a look at the next piece of information. This is the GI pathogens panel. Here that we're looking for viruses, pathogenic bacteria, and parasites via PCR testing. This is very sensitive and specific, looking for the most common causes of acute gastroenteritis. Any findings here would be treated appropriately with standard of care. The next piece of information we have is the parasitology by microscopy. This is a 3-day sample, ova and parasitology. We are looking for 34 parasites and their ova in this section here. Continuing along, we are also looking for other markers under the microscope. In this case, we're looking for markers of inflammation, RBCs, white blood cells, and then some markers of digestion, muscle fibers, vegetable fibers. We're also looking for those Charcot-Leyden crystals and pollen. This is within range here, and we're also looking for yeast under the microscope. The macroscopic appearance, which is very important, is within range for this patient as well. Here we have our microbiology page, and this page provides a wealth of information. The first section is going to be the pathogenic bacteria. We're always looking through for Aeromonas through Yersinia, so that will always be reported as you see here. And then the rest of the report will be individualized for your patient. I've never seen any two reports alike, so this is an excellent opportunity for individualized medicine. The imbalanced bacteria do not necessitate treatment. Those are taking up space in the colon. We do not treat them. But the dysbiotic bacteria and yeast outside the reference interval do have treatment, and we'll take a look at that at the end of this report. And here we have the stool chemistries. This patient's stool chemistries are very within range. Digestion and absorption looks excellent. Those inflammatory markers look healthy as well. Fecal secretory IgA is within normal limits, and so are the short-chain fatty acids. The last piece of information we have here are the intestinal health markers. Recall that beta-glucuronidase is lower, yet that is associated with the diversity here. So this page looks excellent for this patient. We will take a look at the bacterial sensitivities here and susceptibilities. With regards to the Enterobacter species, you have your choice of natural and prescriptive agents as treatment guidelines. With regards to the natural agents, you'd like to use the high sensitivity agents, potentially 2 of them, and you have your choice of prescriptive agents as well, choosing the susceptible agents. You have that same information here for the yeast, again, the natural agents, and then with the antifungals, you have the non-absorbed antifungal and the azole antifungal options. So here you have the treatment guidelines directly from the yeast and bacteria that were cultured in your patient's sample. I hope you enjoyed this case of GI360 today, and please feel free to follow up with us at www.doctorsdata.com to learn more about this and other testing. Thank you.